Thank you very much to Manos and Manos for the fantastic course. It's a pleasure to be here. So, glenohumeral arthritis in young patients is a very challenging problem, both for the patient and for the treating surgeon. These patients have higher demands, greater functional expectations, and they demand greater durability, both in work and in sport. As far as the current literature, it's very limited as far as results in this patient population. There's heterogeneity within the study population as far as the etiology of the arthritis. There are relatively few patients with primary osteoarthritis, and the majority of studies are single center or single surgeon studies, which limits the generalizability of the data. These are the potential etiologies. Not only is there primary, there are also secondary causes, including osteonecrosis, post-traumatic, and post-operative causes. When determining the appropriate treatment, it's very important for us to consider all of these patient factors: the age, both chronologic and physiologic, the patient's occupation, their activity level, sports, if any, that they perform, impact loads that they perform on a daily basis, the disease severity, whether there are unipolar or bipolar lesions, concomitant pathology, and importantly, patient expectations. I'd like to focus on two general arthroplasty options. We did discuss previously Riemann Run procedure, hemi-cap, those sorts of options, but I'd like to focus on hemiarthroplasty and total shoulder arthroplasty. As for arthroplasty, there are several advantages. There are no postoperative restrictions. There's no risk of glenoid component failure. It can work well in many patients, and it's a faster procedure with potential cost savings. There are some disadvantages, however, including less predictable pain relief, less predictable motion improvement postoperatively, and it is not useful in terms of posterior glenoid erosion, as their inferior results have been demonstrated in the literature. For total shoulder arthroplasty, the advantages in general are more predictable pain relief and more predictable motion improvement postoperatively. However, this comes at the risk of the disadvantages of a risk of glenoid failure, restrictions as far as weight and activity restrictions that many surgeons will recommend, a longer operative time, and more expensive. This systematic review out of arthroscopy in 2015 looked at hemiarthroplasty versus total shoulder arthroplasty. It was a review of 32 studies and meta-analysis of these studies. They looked at 459 patients who underwent hemiarthroplasty at average 9-year follow-up and compared them to 203 patients undergoing total shoulder arthroplasty at average 10-year follow-up. The total shoulder arthroplasty patients had better pain relief, better motion improvement, and specifically better active forward flexion and external rotation as compared to the hemiarthroplasty patients. Comparing these two groups, there were similar revision rates as well as similar patient satisfaction with the surgeries. The Mayo group looked at hemiarthroplasty versus total shoulder arthroplasty at minimum 20-year follow-up, and this was published in JACS 2015. This is a single surgeon performed between 1975 and 1985. Patients were 50 years old or younger, and they had 56 patients who underwent hemiarthroplasty and 19 patients who underwent total shoulder arthroplasty with at least 20-year follow-up. The 20-year survival for these patients was 75% for hemiarthroplasty compared to 83% for total shoulder arthroplasty. This difference was not statistically significant. 81% of these patients rated their shoulder much better or better than pre-op. The modified NEAR ratings and patient satisfaction were similar. However, there were a good number of patients who had unsatisfactory NEAR ratings by classification. The reoperation for glenoid problems, not surprisingly, for hemiarthroplasty, the most common cause for reoperation was glenoid erosion. For total shoulder arthroplasty, the most common cause was glenoid loosening. This is the Kaplan-Meier survival curve looking at reoperation-free survivorship for this patient cohort, and you can see that hemiarthroplasty and total shoulder arthroplasty are very close as far as the follow-up for this group of patients. Also out of Mayo Clinic, continuing with this study, both hemi and total shoulder arthroplasty provide lasting pain relief and improved range of motion. The range of motion gains were maintained compared with earlier follow-up studies that looked at the same cohort of patients. There was a significant rate of component loosening or shift in component position, especially in total shoulder arthroplasty. So although both hemi and total shoulder arthroplasty have survivorship in excess of 75% at 20 years, the authors concluded that surgeons should remain cautious in performing shoulder arthroplasty in the young patient. Dr. Walsh and Dr. Nathan out of Lyon looked at a retrospective cohort multi-center study looking at patients age 60 or younger with primary shoulder arthritis at minimum 24-month follow-up. For 202 patients with total shoulder arthroplasty, revision was performed in 16% of shoulders, and again, 88%, the large majority of these revisions were due to glenoid failure. Hemiarthroplasty was performed in 31 patients. Again, 16% of these shoulders had to be revised, and again, the large majority of these patients were due to glenoid erosion. They found that total shoulder arthroplasty had significant better range of motion, significantly better pain, subjective shoulder value, and constant score when compared to hemiarthroplasty. There was no significant difference in longitudinal survivorship, and they also found that earlier revision of the arthroplasty was performed in the hemiarthroplasty group, and there's a more precipitous decline in later total shoulder arthroplasty after 10 years. It dropped pretty significantly. Again, out of Lyon, a retrospective multi-center study looking at patients less than 55 years of age. There were 52 patients who underwent total shoulder arthroplasty. The age-adjusted constant score improved significantly from 37 preoperatively to 73 postoperatively. The forward flexion again improved significantly from 97 degrees to 128 degrees. And the constant score was 80 in patients without glenoid revision, and of course dropped to 43 in patients requiring a revision of the glenoid component. The reoperation-free glenoid component survivorship was 98% at 5 years, but only 62% at 10 years. So again, it's a very, very important number to take into account, that we do see a pretty significant drop-off in terms of the survivorship of the glenoid component in total shoulder arthroplasty in this age group. Factors associated with survival of the glenoid, the most important was anatomic humeral component positioning. So it's essential to avoid an oversized or incompletely seated humeral component, as this caused the greatest risk of glenoid failure in this cohort. Also, the preparation technique of the glenoid was very important. Looking at return to sport, there are several studies that have looked at this after total shoulder arthroplasty. The last one, Liu et al. In 2017, was a meta-analysis and found a 93% return to sport after total shoulder arthroplasty. And you can see that the rest of the studies have a majority or a large majority of patients able to return to sport after total shoulder arthroplasty. So if total shoulder arthroplasty is going to be performed in a young patient after extensive counseling and considering other treatment factors, it's very important for us to consider the factors to do a successful shoulder arthroplasty. These include preserving the bone, minimizing the glenoid reaming, ensuring that the backside match is accounted for to avoid the rocking horse phenomenon. We want to avoid humeral head glenoid mismatch and minimize eccentric loading by taking component positioning into very careful account, and to make sure that we have appropriate soft tissue balance. It's also important for us to discuss the durability concerns with the patients and to make sure that they really understand the durability concerns. So in conclusion, arthroplasty does remain a treatment option in young patients with glenohumeral arthritis who have failed conservative measures. However, it should be used with significant caution. It's important for us to understand our patients as far as their work and sport. It's important for us to understand their disease characteristics, their needs, expectations, and in order for us to help them select the best surgical treatment option for them. It's also essential for us to counsel our patients regarding the risks, especially durability, the risk of glenoid loosening, and the potential need for revision surgery in the future. Thank you.